started.
Okay.
So hello everyone and welcome to General Internal Medicine Noon Conference / Residency Noon Conference / Prep for Residency / Prime Care Weekly Talk. So thanks to everyone who is joining us today. We're really excited to have Dr. Starr Steinhilber, who's UAB through and through med school residency, and we were lucky enough to recruit her here to stay with us in the Division of General Internal Medicine. Usually her job is fairly different than what she spent doing the past couple of weeks since COVID started. She, like many people, pivoted and offered her skills to help with the large amount of employees who were dealing with URI symptoms and symptoms of COVID and who had exposure. So she has accumulated a lot of experience over the past several weeks helping people through managing symptoms as an outpatient, and was generous enough to put it all together into a talk to share with us today. I would like to encourage you to share comments in the chat as we go, so everyone can be an active part. We will have a couple of poll questions as well. And finally, if anyone is interested in the care of the critically ill patient, I've put a link to our lecture from last week, which was with Dr. Sheetal Gandotra discussing care of the critically ill COVID patient. Dr. Steinhilber is going to tell us how to prevent your patient from getting to Dr. Gandotra, and or when to advise them to go to Dr. Gandotra. So without further ado, Dr. Steinhilber.
Thank you. Yeah, maybe more the latter. So I was also going to have pre-announcements, the first of which was this is the outpatient side of care, and the inpatient and critical care we did for Noon Conference last week, which was fantastic. And then an announcement for medical grand rounds next week is kind of a repeat and summary of both. So it'll be 30 minutes outpatient, 30 minutes inpatient next Wednesday. And then for residents on the line tomorrow, so Dr. Snyder sent out a case of the week to think through throughout the week, and then we will debrief it tomorrow at 8:15. And it was a, does the patient have COVID? What do we do next type case. So I'll remind you that at the end, but I often forget. So I thought I'd say at the beginning. So the care of the COVID outpatient, like Dr. Kramer said, I have spent the last 3 weeks really exclusively talking to positive employees. And so I don't know, maybe I've talked to more positives as a single person, myself, Sonia Heath, and some Dr. Overton in employee health, which has been really enjoyable and really enlightening. So I just want to pass on some things we've learned. And I'll say I'm definitely no means an expert, but there is little data. And I should say, I'll let Ryan run the mute button, maybe, if you're able to. And the chat. So I'll try to keep an eye on the chat. If there are things that come up that are pertinent to the exact topic, I'm happy to answer them then, or we'll kind of review it at the end. And I know people are joining. And there's a lot of wealth of information and a lot of wealth of knowledge in this group. So a lot of prime care. So hopefully at the end, we can also crowdsource experience of you guys, as well as people who've had it. So you're welcome to tell us your personal experience. So yeah, I've spent 3 weeks talking to exclusively positive people, and we also call them daily. So it's actually given us a really good idea of how this progresses. And I do not have numbers necessarily on the percentage. I think my favorite quote for COVID right now is, we are building the plane as we fly it. And I think the same, not only for clinical care, but for research. So much of the research that's being published is really how to prevent getting it, or what to do once people make it into the hospital to try to decrease that morbidity and mortality. So I'm a little bit free to kind of give you our experience and some of my information without a lot of papers out there. So maybe we'll get around to that, but it is really interesting. So I will, a few poll questions to start. The first of which is going to be, who has a family member or a friend? Do you just have one? period. This is to see how many people are awake today, eating your lunch, potentially. It does not tell me who says what, so kind of wish it did. All right, I'm going to finish it there, and then I can share results as well. So Brian, will you tell me if you can't see them? Because you know that we have to do this multiple times sometimes. So 91% of you have a family or friend in your life, and I'm very thankful for that. It is isolating this whole world right now, so I'm glad you have someone. Okay, so question number 2 will be, who has a family member or friend who has asked them a COVID-related question in the past 2 months? All right, I hope you can see these. So 98% of those of you with families or friends has been asked a COVID-related question. And then finally, poll question 3 is, how many have a family, friend, or yourself, I didn't add that, who has had COVID or COVID symptoms? All right, so that is more even. So 54% has had themselves, a family or friend with COVID symptoms, and then 46% without. So that's really helpful. A lot of us on this call will not be taking care of people in the ICU. And so it's really helpful to, I hope that some of this will be helpful either for your family or your friends or your patients. So really great to know. I'm not going to go into really details of the coronavirus. We have had some wonderful talks by ID physicians, Dr. Ganjotra, other people. I'll just say, you know, it's the common cold and now the uncommon pandemic. It was detected in 1960s with 4 main types causing the human respiratory illness, such as the common cold every year. And it was that genetic recombination that has really gotten us to where we are today. And they're subtyped by their proteins and now RNA genotyping, which is how we get the different types. And, you know, the SARS-CoV and all of that different delineation. And so that is what we're dealing with. And that is why, you know, you can order a coronavirus lab, but it doesn't mean it's necessarily the one that we are currently dealing with in the pandemic. I'll start with this graph, which you can see this in many different studies and in many different ways. I like this one. And we're really talking outpatients. So I'm going to focus on the clinical symptoms, since a lot of times we don't have signs, we don't have labs or physical exam. And we certainly are a lot of times not giving that bottom row of therapy. So focusing on the clinical symptoms, time 0, usually we call time 0 when your symptoms started. And so there is an incubation period that starts before that. But really the first phase is that viral response phase, early infection, where you get mild symptoms. So fever, diarrhea, headache, dry cough. The second phase is the pulmonary phase, where most people start to get shortness of breath and hypoxia if they were to become hypoxic. When that happens, you can see variable reportings on what days. In general, we say about 7 to 10 days is when, if you're going to get worse, you probably get worse. That leads a little bit into our recommendations for when to go back to work, how long to quarantine, and things like that. And so knowing, you know, it's really nice to know, oh, okay, made it to day 10, you're less likely, I should say, to really get this significant shortness of breath. There's often a question of how fast symptoms come on in people we've spoken to, because we gather a lot of information, if for nothing else, about when you can go back to work and from an employee health standpoint. And so one of the main questions is, when did your symptoms start? And being very specific about that. Most people will say they started, I ate lunch at 12, I felt fine. At 12:09, all my body hurt. So I would say a lot of them come on pretty fast, and it's really that fever, myalgias, headache that are really starting. If you talk about when should you start getting better, just to kind of finish out the time course, because if you see this graph, people who would get worse, go into the ICU, and we're going to ignore that side for now and talk about kind of this pre-phase, the earlier phases in stage 1 and 2. This is another timeline from China, which was trying to show when most people get admitted and things like that. It still shows this 5-day incubation period, day 0 when symptoms start. And then it's really one of the main places I saw a date for when average recovery time for mild disease was day 14. And there's a lot of things that go into that. I would say that for mild disease is full recovery, meaning you are 100% back to normal. And so we'll talk about that as well. Longer recoveries if you needed hospital admission. So symptoms, this is a lot of what we'll be dealing with in primary care. And so I want to talk through some of the symptoms first. So fever, I'm going to already stop and pause on fever. This is data, and you'll see it presented multiple ways in different studies, but it usually is all the same numbers, and it's from the Chinese version of the CDC. And so they say fever is about 88%. There's a small study in Seattle, a really small one that I think was 24 patients, and they said about 50% had fever. And in all of our phone calls with employees on the employee health side, my view was 88% is way too high. Most people are saying, I feel really warm. I feel hot, but I take my temperature and I'm 99.8 or I'm 99.6. And so that number seems really high. There has been, and I don't remember if it was a study or just a suggestion that actually Ryan Kramer showed me a few weeks ago, that there's a suggestion that our basal body temperatures are actually lower on average than the 98.6 that we continue to quote, and maybe most of us live in the 97s. And a lot of employees have told me that. They've said, I'm 99.8, but usually I'm 97. And so that we would consider, a fever. It doesn't meet the 100.4. So if you look back at this China data, which I've referenced in the bottom right, what they used there, it was the Guan study, was a temperature over 37.5, which is 99.5 Fahrenheit. And I did not look back at the Seattle one, but I imagine they use 100.4 to get their 50%, since it's in the US and with SIRS criteria. And so it may be more like 50%. I think a lot of people have low-grade fevers and not quite the 102, 103, 105 that we initially heard before it really hit us. So fever is very interesting. A lot of people feel warm but are not reaching the 100.4, so don't write that off. Dry cough, very common. Fatigue, maybe some sputum, shortness of breath, myalgias, headache. I'll comment on the diarrhea. So diarrhea was quoted out of China, about 4%. There has been data out of the US saying it's maybe more like 10%. I may even think that may end up being low. Our main symptoms when we've been screening people for COVID have been shortness of breath, fever, cough, and myalgias. So we have not been as proactive asking about diarrhea, and people don't tend to want to divulge their bowel habits if they don't think it's important. But when we have asked, or people who have volunteered, I think diarrhea being one of those preceding symptoms, even before a fever or at the same time of, it may be, I would say it's definitely higher than 4%, and I don't know if it'll end up being higher than 10%. One other one that's not mentioned that many of you probably have heard is anosmia. So changes to smell and taste, I would say is a very specific symptom. So maybe not sensitive, but very specific. And if you have somebody that has a fever, a little bit of cough, and all of a sudden lost their sense of smell, that has never happened in their lifetime, they have no other reason for that, I think that they are a presumed positive COVID patient. Even the American Academy of ENT has advised that anosmia, hyposmia, and dysgeusia be added to the list of screening symptoms for COVID. So everyone's recognizing that as a significant symptom. Who gets what, and this is why we're talking about it today, is because 80% will be kind of stick with us, stick with primary care and not need to go to the hospital, which is fantastic. The China study, as Dr. Gandotra mentioned in her talk, said 80% mild and then 14% severe. And there's obviously a bridge between mild and severe. So if you really expand that 80% for mild to moderate, which can include some very mild shortness of breath, can include some mild pneumonia, and really severe being necessitating oxygen and necessitating hospital admission, and then the critical being that 5% that we've probably seen. So, you know, we will be taking care of most of them, and that's a good number to remind people too of, you know, that number can be helpful to a lot of patients to know that they're probably going to be okay. So setting expectations, knowing these numbers, I think is one of the best things we can do in primary care. And so saying 80% stay home and are fine. So take that encouraging, you know, and an encouragement. Our residents and definitely frontline providers, often we only see the worst, right? We only see the ones that are admitted or potentially admitted in the ICU. And so we get a little shift, our mindset shifts to worst case often. And that's one thing that, you know, working on the employee health side, I have felt much better about COVID than I did before, because nearly everyone, well over 80% of our positive employees are home, never went to the hospital, or fine. And so it's actually been really encouraging. So telling patients, you know, they only see what's on the news often, and that yes, there are some bad outcomes, but most people are not the people that make it to the news, and we're going to assume you won't be either. But do tell them you will likely get new symptoms. So the closest thing patients compare this to is the flu, as far as the fever, myalgia, is not feeling well. But with the flu, if any of you had the flu, most people would say they got hit by a ton of bricks. They had all of these symptoms at once, and then each one kind of slowly got better over time, which is different than how people are describing COVID. So SAG reported, I think in one of his interviews, that it was like Groundhog's Day. And a lot of people have likened it to a roller coaster. So they'll say, I felt terrible last night. I woke up this morning and I thought I could even go to work. This is great. My shortness of breath is gone. My fever's gone. And then by noon, I felt terrible again. And so warning people that happens, and that just because you had one good day does not mean you're done. And just because you had one good day and got worse does not mean you now have COVID a second time, or all of a sudden have pneumonia, or all of a sudden have COVID and the flu. So expectations, I think, will help patients have less anxiety, and then help you potentially field less of those phone calls as well. There's a Mass General table about risk factors for COVID and getting worse. I show this, you know, there's 3 columns. There's the patient demographic risk factors, vital signs, and labs. And most of the time with our televisits, we do not have the vital signs and certainly don't have the labs. So focusing on the risk factors, they recently, Dr. Gandotra showed the same table, and the age was 60. And between last week and this week, they've changed that risk factor up to 65. And then many other things that you have already heard about already having chronic lung disease, kidney disease, hypertension, cardiovascular disease, diabetes, obesity, and any reason to be immunosuppressed. They, you know, these are helpful. I think they're helpful mostly to providers. So if you have patients that have really high health literacy, I think that you could use some of this information to encourage people to take it seriously who aren't. So saying, look, you have diabetes, you really need, or your family has diabetes, you need to not go around them. But I do caution you from saying, you know, you're an African American with hypertension, so you have a higher likelihood of doing worse, because that's going to cause even more anxiety. And I mentioned African American, it's not on this list. Dr. Vickers sent out a great email with a lot of percentages that suggest that African American population is doing worse, and whether that's a genetic issue or just a comorbidity issue with the same things on the list is yet to be determined, but social determinants of health definitely playing a role. So one thing I would encourage you to potentially use this list for, if your bandwidth allows, is if you have patients in this list, is this someone that you would call to check in on? I realize in primary care and adult primary care, the chances of nearly all of your patients having one thing on this list is very high. But I'm hoping you don't have that many COVID positive patients. And again, it's COVID. I didn't know if I mentioned this, but this whole talk is surrounding COVID, like tested positive or presumed positive. So typical symptoms, whether the test was negative or they weren't tested. And we'll talk about retesting as well. So is this a group that you or your nursing staff could call daily to check on? I mentioned we are calling all employee health, from employee health, we're calling all positive employees daily to check on them. And that is high risk or not high risk. And that's really helpful because most of them have high health literacy. But you would imagine if you didn't, a lot of patients may be staying home because they're saying, look, the news said do not go anywhere for any reason. And so I'm not leaving my house. I don't care if I'm short of breath. I don't care if I'm using my inhaler once an hour. I'm not leaving my house. And so actually hearing from a nurse that says, no, you sound worse. Let's make another plan could be good. So one opportunity to use some of this information to risk stratify your patients for their benefit. I don't know about sharing all the details, though I'm sure this is public knowledge somewhere that they could find. Let's see if I can get back to this. Okay, so what do we tell them to do? So if you're positive, we'll start with some advice. The first is, if you can separate yourself, please do. Separate beds and separate bathrooms. Not everyone will be able to do that for space reasons, but it is ideal. So bathrooms, you're touching a lot of the same things. There's a lot of stainless steel, which can have virus and fomites living on it for an extended period of time. And then beds, you're often closer, your heads are closer than they would be with our 6 foot ideal distance, or even if you're talking to someone. And then of course, coughing and sneezing and breathing overnight puts people at risk while you're sleeping, and you don't really have the ability to control what you're doing when you're sleeping a lot of times. So that is one big thing that we are advising people if we can, which may or may not be able to work depending on your home situation. The second is, for a little comic interlude, I Googled homemade mask, and this is the first one that popped up, which is a very well-fitting bra mask. And just a reminder that, the CDC has said, please wear a mask when you go out in public, wherever you're going, grocery shopping, picking up dinner, whatever, or going for a walk potentially. But in people who live in a home and they are positive and they're trying to protect other people, then wearing a mask at home is great as well, if they have the ability to do that and then they have the resources or they have masks or are able to make a mask. It's the same theory behind us doing universal masking at UAB, which is it protects, if the sick person's wearing a mask, it protects them from spreading the virus. And then if a healthy person's wearing the mask, it prevents it from getting in their nose and their mouth. So even a mask inside your home for these positive people, if they can't separate themselves, is a good idea. One of our residents a positive resident had the ability to go live in his basement, and his wife was very safe away from him. But if you're not, then a mask could be a good thing. Over-the-counter medications. So as I'm sure all of you know, COVID right now is supportive care pretty much. And that goes the same for outpatient. And anything they can do to make themselves feel better while time helps take care of this, we support. I won't go into the nuances of NSAIDs versus Tylenol. I will just repeat what Martine Rodriguez said about 2 weeks ago, which was, we don't know. So if you have the ability to take Tylenol, let's just take Tylenol while we figure it I personally, on a regular day, much prefer NSAIDs for aches and pains, but would 100% switch to Tylenol if there is anything to that. So if no liver disease, and if all else equal, let's go with Tylenol. And then any over-the-counter cough medicine, this cough is similar to any cough, which is not much cough, suppressants help. And coughs just tend to linger until time and everything else resolves. So anything that they are able to try. Again, you've got to remind them if they have concurrent hypertension, to not do some of the, the combined medications that may exacerbate that. But over-the-counter medications are really what most people are using. And then being able to treat what you can. So this talk was originally, Dr. Kramer was going to do allergic rhinitis, and I was going to follow up with COVID, but mine blew up and blossomed, and I told him I didn't have enough time, and he gave me some of his back, which was kind. But it was intended to be together because one of the biggest things you all are dealing with in clinic and that we've been dealing with is, do you just have seasonal allergies or do you have COVID symptoms? Sonia Heath told trying to educate a patient once that if all of your symptoms are neck and above, then it's probably allergies. If you have some symptoms kind of throat down, then maybe it's COVID. That summary is, of course, not 100%, but it was really helpful. Watery eyes, sneezing, and then, sore throat and things like that. Maybe more likely to be allergies. I will say sore throats in both. So that alone doesn't necessarily help. But if you can treat allergic symptoms and give them some cetirizine right now, that's great. If they have sinus pressure, please treat that with antibiotics or rinses. And then flu, at the very beginning of this, if you all will remember, that was really the diagnostic and testing pathway was, do you have flu symptoms? If yes, let's test for flu. If flu negative, then we consider COVID. The good news is social distancing has pretty much killed flu. So that's good. We have not seen very many flu positive. It is also not a requirement anymore for testing, which is good. It does show you how, not being around people, you can keep yourself much more healthy. Same thing with many less kids in school. My toddlers are not getting they get every kind of fever, rash virus in the spring that's possible. And we've been incredibly healthy. So that's one positive. So treating that if you think they were to have flu, or test positive for flu, treat that. Anything that we can do to help rule something out and take it off the table and make them feel better. And then we talked about congestion and cough. So one question, of course, that gets brought up is, should you, as primary care, give them azithromycin, hydroxychloroquine, and steroids? I'm going to say the short answer right now is no. To summarize succinctly, it is postulated there is a role for at least those first two. There have been promising small studies. There have also been examples where it made people worse, even from just a respiratory COVID standpoint. And then, of course, there are many examples of them either alone or in combination causing arrhythmias with the QTC prolongation. So right now, from just a general outpatient standpoint, the party line from ID in lots of places is, let's not do it yet. I will say there's a UAB trial, which I mentioned at the end, for azithromycin and hydroxychloroquine in the outpatient setting for new COVID patients. They have to start the first few days of diagnosis and be followed for 21 days to get the full study. And that's anticipated to start May 1st. So I think it was first announced in one of the mass UAB emails yesterday or the day before. So keep an eye out for that. So that's hopefully coming. And then steroids. So generally the thought is, don't give someone steroids just for COVID if they need steroids for something else. So they have a COPD exacerbation. They did test COVID positive, but they're now also in the middle of a lupus flare. Then you could use steroids for those appropriate flares or those appropriate diagnoses, but maybe not just for COVID right now. So hopefully more to come on that. But for now, we are not supposed to be giving out these as just treatments or as post-exposure prophylaxis, which is one of the big things that had been talked about for hydroxychloroquine. So hopefully more to come on that. I don't know if many of you talk to many positive patients, but a lot of people get worse at night. And it's interesting why that is, and a lot to be studied about that. So one question comes up, would prone sleeping help? And there is, Mass General does have a prone positioning for non-intubated patients guidelines. I have a PDF link for that I'm happy to send. But also if you Google that, you can pretty easily find it. And I don't think this photo was from that, but it's pretty easy. So it's basically sleep on your stomach and put yourself up. What they say is start with 1 hour and then do it as often as tolerated. And the requirement is that the patient is able to turn over, and so they don't get stuck like that. And that's really more for maybe inpatients with decreased mobility, for having the nurse put them like that and them not being able to get out if they got into trouble. But at home, you would imagine if they could turn over, they can also turn back over. Dr. Gandotra, again, pulmonary critical care, mentioned that there's evidence from China on awake proning in hospitalized patients, but it would be very similar. And so she said that the few they've done at UAB seem to help oxygenation, but that was a very small number. And though it did help oxygenation while proned, I think those people still ended up intubated. So more to come. But I think at home, there's really not a downside. And so I think patients are happy to, or we are happy for them to try that as an option. So we'll talk about how to tell if you're getting worse and how to advise patients on if they're getting worse. I will say if a pulse ox is our very best friend right now. Most everything is symptomatic or, subjective symptoms, including shortness of breath. If they have the ability to take their oxygen sat occasionally, whether that's at rest, at walking, when they're short of breath, is incredibly helpful as one of the few objective things people can do at home to help you guide your decision making. Dr. Willett bought quite a few on Amazon when this started, and we've been handing them out to residents who were sick at home and had COVID so they can try to stay home. Everyone wants to stay home if they can, and that was really helpful. So if there's the ability for an oxygen sat, that's wonderful. But again, on a large scale, that may not be something that's been able to do, but you can always ask, or if their neighbor is a nurse or something like that. But how to tell if you're getting worse. So breathing. That is really the main thing we're focused on. If your nurse does start calling people every day, then that's what he or she should ask the most about. We tell people all the time, we expect you to have multiple days of fever. We are not surprised if it's not gone at day 3. We expect for symptoms to come and go, like the roller coaster we talked about, and most people will develop a cough. So please, if you're not calling people, which is totally fine, I'm not sure bandwidth would allow, have them call you with their new symptoms. They can send you a portal message and just let you know how it's going. So if you hear something worrisome, that you can call them. So trying to get more specifics on their shortness of breath is, are you more short of breath putting on clothes, going to the bathroom, at rest, trying to just make a sandwich for lunch? And if they are if they are an inhaler user from asthma, then asking about their inhaler use is actually a really helpful objective symptom sign that has helped us a lot in some employees. It's a little tough because it is allergy season, and so most people would have increased their inhaler use right now. But if you know they're COVID positive, then just assume it's COVID, and maybe they have both, but you don't want to write it off. One comment on inhaler use. So Similar to the inpatient side, where we are decreasing our use of nebulizer machines in order to not have as many aerosolized particles, we would advise the same for patients at home if they have the MDI inhaler instead of the nebulizer. So if they can use the MDI and not their nebulizer, especially if they live with people who you want to keep from being more exposed, and that would be great. If you have a patient who has really severe COPD at baseline and already needs a nebulizer every 3 hours at home just to have his or her ideal lung function at baseline, then we wouldn't want to take that away. But if you have the ability, the MDI, the little individual one, is much better. This is what, if you look up at UAB in the depart section, whether you are departing a patient from clinic, from a televisit, or from the hospital, if you look up COVID instructions, or from the ER, I should say, this is what it is. And they, I believe, well, I looked up this morning, they combined them all. There used to be other ones for clinic, I think, and now they're really all into one. And this is what they say for patients. This is how you know you're getting worse. So there's the breathing that we talked about at the top, chest pain or pressure, new confusion, and then, turning blue, which would suggest obviously the hypoxia. Those two, I mean, the third one, confusion, right, is a sign potentially of sepsis or something getting worse, and having poor perfusion. It's a little hard to remember all these things to tell patients. So I think if you focus on the breathing, which is most common, and if they have the ability to have this list, then that would be really helpful too. But this is what you'll find there. There's also a 2-page PDF with home care instructions that UAB made. It is probably floating around in your email. I don't know of a centralized place it is kept, but Dr. Snyder did help me find it this morning, and we can send that out too if it is not somewhere floating in your email, but it talks about a lot of the same stuff that we're talking about today. So when to be seen? When should you yourself be seen, tell your family to be seen, or as the provider need to see someone? The first thing we'll talk about is COVID test or COVID retest. So the COVID test, when we talk about sensitivity, the number floating around nationwide is about 70% sensitive. So a decent amount of potential false negatives. When the 70% number was told to the head of the lab at UAB, he was very offended and said that it is much closer to 95, which would be great. So we'll see. I would love it to be closer to 95, and I think the truth is probably somewhere in between. I think that could be a negative test in a very classic presumed positive patient, could be for a number of reasons. I think the first one could be swab technique. We were allowing, I say we, partially employee health, partially just UAB community testing, was allowing self-swabs initially to decrease the exposure to the nurses and the PAs and the physicians. But I think we were getting a lot of negatives because it is really hard to, for lack of a better word, jab that thing deep enough into your own nose. So we are not doing self-swabs anymore, and now they are all done for you. And for the patients and the residents that I've talked to who did have to, they have always said, oh yeah, I totally didn't do that right, because that second one was way worse. So most people you talk to will say, oh, my eyes were watering, it was terrible. They definitely got a good sample. So one test would be swab technique. A second option for a negative test that you maybe don't believe is testing too early. So initially, when we were behind on being able to get the tests up and running nationally, we had a backlog of people with symptoms who we needed to test. But then we caught up, which has been wonderful, at least from the UAB employee standpoint. So if you have your first symptom on a Monday, let's say it's fever, and then we are able to test you Monday afternoon, Tuesday morning, that actually may be too early. So it may not, but there are quite a few that the initial test was done kind of the day of first symptom or the day after. And you wonder then if there is some suggestion that patients have not had an opportunity to mount enough viremia to be detected on the test. So that's one other option. If you, and then the third option for a potential negative test are just differences innate to the person. And I don't really have any data on that. This is just a hypothesis of mine, in that This virus does enter through the nasopharynx and then really it loves the lungs, and that's where a lot of the ACE receptors are. But it also can get into cells in the posterior nasopharynx. But I wonder if it's doing, if some people are having more kind of get back there and some people are not. They're just having more in the lungs, because we have had plenty of employees, residents, patients who have very classic symptoms. So they're young, they're healthy, they have fever, they have myalgias, they have a dry cough, and they have anosmia. And now they've had 2 tests that are negative. And it may be test characteristics, but it also may be the person characteristics that we don't really know yet. So again, pure speculation, that I have no data to back that up, but it does make me wonder, because we're really just swabbing the posterior nasopharynx. But if you are negative, and if you think they could be it may not be true, then you can retest. And we have the capability, meaning the bandwidth in our testing right now, to do that. Is it necessary if you think they're presumed positive? Probably not. But we are doing it to try to get some better test characteristics at times. So that's one reason to be re-seen. The second is if you clinically think they are need a chest x-ray or oxygen saturation. So if they don't have the ability to get a pulse ox at home, and it's very difficult to try to get those things done now at places where they used to. So for example, fire stations and CVS. So if you think they need to be seen for those things, then that would be one reason to ask them to come in or go other places we'll talk about. And then always using our clinical reasoning, could there be a different diagnosis? Could there be 2 diagnoses? If these are positive or presumed positive, then could they have 2 things? Or we called them presumed positive, their test was negative, and the main symptom to get screening, to get testing, has been shortness of breath. And as all of you know, there's so many things that cause shortness of breath. So did we potentially go down that route when it really is more likely to be their heart failure or something? So all reasons to be seen. And then where to be seen. So many options. You or we could see them as televisits, as these new drive-by visits, or in person. So that's one option. The other is the UAB COVID clinic, which many of you probably know about. It opened last Thursday. It is being staffed primarily by Doctors Overton and Sag. It is an afternoon clinic, and they are doing a really great job getting people in same day. So if you ever have someone in the morning who you know is positive and is not getting better or is getting worse, then they could, I think, via visit ability, easily get them in the afternoon. And there is a process to do that, which has been sent out in PDF form. And I have successfully, it is 3 steps, and I've successfully done it multiple times. So it's not difficult, but it does take a second. Their ideal patient is the positive or presumed positive, who is not getting better, who is getting worse, or who may need one of those things above, an oxygen saturation or a chest x-ray, and they have other labs, EKG, things like that. It's a really good buffer between staying home and then going into the hospital. So I've sent quite a few people there. So they will walk people with an oxygen saturation on how they're doing. I sent one.
Starr,
yeah.
I think you're okay. I think you're back. Your volume kind of cut out on my end for a minute.
Oh.
So maybe
How long ago was that? Hopefully not long.
3 seconds.
Okay. I was talking about the COVID clinic. Am I good volume-wise? Hopefully, volume. Should I keep talking?
You're good.
Okay. So this one patient, they did a walk test, and the within 40 seconds of actually walking in place, she dropped 5%, and so they admitted her for observation. So it's really helpful. The other options are inpatient direct admission. If you have the ability to say, I know their oxygen sat and their pulse, because they have a pulse ox at home, but they're not doing great on the phone, they're talking in shorter breaths, things like that, then you can just directly admit them to the hospitalist service. And that's nice because they bypass the ER and expose less people down there. So that's definitely a benefit. If you don't know how severe they are, though, of course, if you're not sure they're stable enough for floor or for ICU, then definitely go through the ER. Please give the ER a heads up if this is a known COVID positive patient. They have that COVID pathway, which is really nice to try to get them, again, less exposure to the rest of the people in the ER. So that's been I think, really successful. So those are a lot of good options on where to send them. So when can you go back to work? Always a big question. The party line is 7 days from symptom onset and 3 days asymptomatic. And what does that mean? So the hard rule is no fever. That is CDC. That's what everyone says. Again, a lot of these people have 99-degree fevers, not 100.4. So if someone's still in the 99s, I would say, I'm calling that a fever. We're going to keep counting. As soon as you're fever free, we'll start your 3-day count. I lump fever, chills, night sweats, and myalgias all together because I think that they all signify inflammation in your body trying to fight it. So I put all those together because if you had a night sweat at night, you probably had a fever at night that you didn't get to check. So I add all of those together. What brings up the most questions is lingering cough. And as all of you wonderful primary care doctors know, you've advised thousands of patients that their cough is going to last much longer than their pneumonia, or much longer than their URI, or much longer than their flu. And this is no different. How long should people have a lingering cough is unknown at this point. Again, only from my experience, from all the positive employees we've had, my summary now is the worse of a cough you get, the longer it's going to take to go away. So some people get a dry cough and it is 2 days, and then they may cough twice on day 3, twice on day 4, and that's it. But the people who get a significant cough, it takes a longer time to go away. There is data to suggest that after about 8 days, so day 8 of being a known positive, or if we had a day 0 when you were positive, around day 8, you're no longer spewing virus when you cough. So that's a good thing. That is an average, but that's good. So if someone is now going back to work at day 14 and they have a lingering cough, they are unlikely to be infectious. Of course, if you're going back to work and you're saying, hey boss, I'm COVID positive and I'm coughing at work, then everyone is going to be on edge. So a mask is good. I think it would calm the anxiety of your coworkers as well. But there are people that may have a cough for weeks after, who want to go back to work and are needed to go back to work. So that's a little tough to determine. And then the last question, we used to be saying, okay, 7+3, go ahead. But now we're doing a little more questioning on, can you do a full day's work? Because even though a lot of your symptoms are gone, potentially by day 7, let's say day 9, most people don't realize how exhausted they are. And even one of our residents went back to work, was COVID positive, stayed out appropriate amount of time, if not more, and was eager to go back, like many people are, because most of us are not good at just sitting at home. And we want to help. We want to help what's going on. And so she went back, and then she said the next day, I'm so thankful I just happened to have a half day of work scheduled because I did not even know how exhausted I was. And I think that's really common. So the goal for a return to work is the minimum. We do not want people going back before they're ready, and we don't want employers forcing you to go back before you're ready. And UAB has not remotely done that, but that's why these days are set. It does not mean you can't stay out longer. If people say, I don't have a shift I know you said I could go back, I don't have a shift for 5 more days, then please stay out 5 more days. That does not mean you need to go back to work today. We're just trying to give the minimum. And if bandwidth allows and you've got enough people, like, please stay out. So that's been, helpful, and being able to kind of stay, hopefully. And the last thing on that is Jefferson County Department of Health and ADPH have been sending people letters who are positive. Again, it's reportable. So all of our positives get reported to the Jefferson County Department of Health, and they are sending letters in Shelby County, all the counties, and they are serving people letters. So an official law document that says you have to quarantine inside your house, you and your family, for 14 days. So we've gotten a lot of phone calls that have said, hey, employee health, you told us I'm good. You told me I'm good, but I got this letter that says 14 days. And this is my kind of, they win. So what they say beats us. Even if they had a return to work letter from us, if they have a return to work letter from one of you as a primary care, we don't want anyone going to jail. We have a really good relationship and a really open, direct line of communication from employee health to the Jefferson County Department of Health, such that if we have someone we feel like is cleared and wants to go back and needs to go back, we're able to communicate that to them, and then they call them back, do their own assessment, and then almost 100% of the time they have agreed. We do not quite have that relationship with Shelby and some of the other places. And so when in doubt, we've told the employee, well, just see it as another few days of vacation with your family. Not that quarantining with kids is a vacation, but just stay home. We don't want anybody getting in trouble with the law, and UAB is thankful right now to have a depth of providers currently without the surge. So if you get that question, this is our minimum, but if they say stay home. Okay, a few last things is, what about my family? It is separate best you can. No hugs or kisses, no eating or drinking after others. That goes for all of this. Family does need to isolate 7 to 14 days. Again, incubation is about 5 days. 95% will show symptoms within 7 days. And so if you're counting your 7 plus 3 and they're there with you for that 7, then you will know by the end of your time if they have developed symptoms. So they just need to hang out with you, although as separate as possible. And lots of questions about dogs and kids. And in general, they can get it. If you think your child is sick, of course, consult the pediatrician, unless you are med peds on this call, most of which are not testing most of us are not testing for contacts because the testing ability, but trying to keep them clear for family. If family and others want to know if they have it, there's 3 that I picked up. Coronavirus self-checker is on the CDC. The Human DX has one, and then Apple made one. I did all 3. All 3 ask you about your symptoms: shortness of breath, cough, fever, myalgias, all of those, and your risk factors. So those same risk factors: diabetes, hypertension. And most don't give you an actual score, but if you score high enough, it says call your doctor. So maybe that's helpful, but it gives patients and their families something to do. So that's one thing. And then I see Dr. Snyder is saying UAB also has one, has a coronavirus self-check. So apologize for not including that one of our own home institution. Lots of questions about, should my family member get tested? I think this is just a great 1-page flyer on testing does not change treatment. With limited capacity, we are not usually testing, and most places are not testing asymptomatic people. So I tell them, if they get symptoms, if your spouse gets symptoms, I'm going to assume they're positive, and I don't care if they are tested or not. So, from an epidemiology standpoint of the virus, it would be wonderful to know every positive so we have accurate data. With the limited testing, I don't know that that's possible. So really just telling them to stay home as if they're positive. The few people who really do want to be tested or need to be tested is for work, whether their job needs proof of a positive to let them be out of work, or proof of a negative for them to continue working. So that's one, that is one thing that you may have to deal with. But in general, it does not change management, as most of you know. So there is a page with CDC advice on preventing it. There's a lot of data out there on how not to get it and what to do for providers if you're in the ICU, but there isn't a great place to lead patients to how to, what can I take, what should I take at home. So this is my last slide. On the horizon is that azithromycin hydroxychloroquine study starting May 1st-ish, we hope. I'm hopeful that we have low numbers then, so their turnout isn't good, but I think we will probably have plenty for them to enroll. And then antibody titers, right? The test currently is a PCR test, so getting antibody tests, whether for active infection or immunity, is absolutely in the works. There's a few labs, including Sonia Heath's lab, that is putting that together right now and doing that as quickly as they're able to. I'll say, if you've heard, UAB sent out an email about getting the private labs doing antibody testing, because a lot of people are interested in that in the community, and they discouraged going to it for now. Not only is nothing FDA approved, which nothing may be because of how long that takes, but it's questionable whether that the results are really validated and whether they're helpful. So there's, did you have IgG? Did you have IgM? What does that mean? I would love an antibody titer, and I'll probably get one when UAB does it, or when UAB does a study. But for the community in general, UAB has said maybe advise against that for now because it's just really difficult to know what to do with those results. And then again, antibody titers study being helpful to then create convalescent plasma to give patients who are doing poorly in the hospital. And then we have the remdesivir inpatient trial and a few others, but I wanted to mention those top two because those will probably be pertinent for outpatient, especially the top one, which will absolutely be pertinent for outpatient because they need referral as soon as that positive test comes back. As usual, when you get talking, you don't end up leaving as much time as you want for comments. And then here are the two, again, two announcements. If you missed it at the beginning, Grand Rounds next Wednesday from 12 to 1 is 50% outpatient, which will be similar information, and then 50% inpatient care of the COVID patient. And then for residents, the discussion of the patient case she sent out before morning report tomorrow from 8:15 to 8:30. So Ryan, you may have been, I've read none of these. I decided I couldn't multitask and keep up. So if you have any you want to add or comments or even questions, or if people want to raise their hand actually in the box to give some of their advice, we're all happy to hear it.
Yeah, so I'll ask one question, and there's been some great commentary in the chat as we're going, but what I'd ask is anyone that has a question for Dr. Steinhilber to answer, if you would just re-put it in the chat now, if it wasn't answered during the talk, or raise your hand. So one of the things that I heard about early that scared me about COVID was hearing about reports of patients who felt maybe a little short of breath, not much, but then when they were tested, they were fairly hypoxic. Have you run into that at all, either with patients testing at their home pulse oximeter and being surprised by it, or by coming to a respiratory clinic or ER or something and then kind of being surprised that they were hypoxic?
Yeah, so no group data because there's just nobody publishing things like that right now, but absolutely more anecdotes. So on both sides, I felt really short of breath, but I was 99%. That was surprising. Or I'm not that short of breath, but I was 89 in a very healthy young person. The lack of pulse ox, similar to maybe lack of testing in large groups, has really prevented knowing a lot of information on that. But Dr. Gandrotra even mentioned that it's hard to know when to intubate because patients may look good, but then you get a pulse ox and maybe follow up with a VBG and they're not oxygenating well. So I do think having that objective data at home is helpful. I will say the younger you are in most things, the better you hide things. So it's just a little difficult to decide, which is why I think even going for a pulse ox check at that COVID clinic would be really helpful.
Fantastic. So we are at the hour, so anyone that needs to sign off, please feel free to do. But if Dr. Steinhilber can stay around for a few more minutes, anyone that has a question, please either put it in the chat or raise your hand on the hand function, and we can go ahead and call on you and answer it.
Let's see if I can open all that up.
Or alternatively, you can take yourself off mute and just ask it. That would be another way.
Dr. Steinhilber, this is Mark DeCola.
Hi, Mark.
Hi. Can you just comment for patients who may be concerned about the testing experience and what they can expect for us to pass on that information? So maybe scared about even going there, whether they're going to get infected if they were actually negative, and just comment about that experience.
Yeah, I didn't know which part you meant, the jabbing of the nose or the risk.
Well,
so the risk,
all of it.
Okay, the risk, nearly all testing sites are making you stay in your car. You have to have your window up the whole time, which has its own other issues. So you shouldn't, and the people administering the test are in full PPE. In fact, we're having to, people are having to trade them out so they don't pass out in the sun. The risk of getting exposed while in line, if you will, or getting tested is incredibly low. Now, there is a little bit of concern of aerosolizing your virus if you have it in your nose, so maybe the person in your passenger seat. So that's one option. But their exposure, if negative to get tested, is very low from the people also at the site. I actually would, I don't know. I mean, I know a lot of people in here have been tested. I almost favor not really telling them much other than it's a nasal swab, because the more you know, the more scared of it you are, because it is pretty traumatizing, again, only for 10 seconds. So it's kind of one of those things that I don't really warn my kids before they get shots. They just do it and it's over. I feel like it's similar. Now I'll say, when I have encouraged people to get retesting, they're like, I am not doing that again. So so it's tough. So I I don't necessarily, people want to know, so I don't go into details of how far back they go in your nose and what it should feel like. I did more when we were trying to self swab, so make sure it's uncomfortable, and all of that advice. But now that we're not doing self swab, I kind of think them being nervous about it, it will last much longer than the 10 seconds it takes to do it. But you know, others may feel differently about that.
So Starr, this is Bill Curry. So yeah, a great answer to both questions. The one thing we warn people at the testing site is if they're on anticoagulants or even just aspirin, they're likely to get a nosebleed. So, have some tissue or have something with you in order to manage that. It is not a nasal swab. It's a nasopharyngeal swab. You go in 4 inches and you have to root around if you're going to get an adequate specimen. So it is traumatic. But like Starr said, it's painful for 5 or 10 seconds, and then you may have a nosebleed. But usually not a big nosebleed, just a little one. Yeah. We've had one big nosebleed. That's the only big one we've had.
Yeah.
Out of 6,000 tests.
Good.
We had a question in the chat. Is the 7+3 based on viral shedding? Or where does that 7+3 come from?
Yeah, that's a good question. It is. That is where the 7 started, was the viral shedding. Again, these are not quarantining because you've been exposed. This is, you are positive. And so it's based on the viral shedding, similar to the fact that if you cough, which is supposedly, that and sneezing being the most aerosolization you could do yourself, that we're not finding, I'm not the researcher, but they're not finding particles in a cough or sneeze at about 7 to 8 days. So that is where the 7 comes from initially. And then the 3 is, we wanted at least 7, and then we're going to keep adding 3 for every continued symptom you have, to make sure that if you, both for your sake, that you're well enough to go back, but also if you do happen to be one of these people that's going to shed for a long time, that we make sure to keep you out. Good question from Morgan.
And we had another question from Stephen on, what is the reference standard for COVID PCR testing? Is it the test itself? Is it its own reference? This is something I haven't personally read about, and maybe Dr. Steinhilber or someone else knows. But yeah, when you're trying to come up with the sensitivity and specificity, you usually have a gold standard, but this is so new. Is it, people that eventually got bronchs, or just the whole clinical diagnosis? What was the clinical diagnosis? I'm not sure.
Yeah, I unfortunately don't know. It's a really good question. And so maybe I'll just copy and paste it on Wednesday, if there's time, into Sonia Heath's similar talk. I think a lot of the ID physicians who run labs and have done some of this work probably have an easy answer to that, but I actually don't know the answer.
Ryan Sheets asks, have you seen regarding ACE and ARB use? So we know that it's the ACE2 receptor in the lungs. Are ACEs helpful? Should we put everybody on them? Are they hurtful? Should we stop them in everybody? What do we do, Dr. Steinhilber?
Right now, they're on it, but don't put anybody else on it. I mean, I'm just going to repeat what, both CDC, ID, and the cardiovascular, all the different institutes say, which is, if people are on them for hypertension and different things, then just leave them. And we're not taking them all off right now. You wonder how much we'll know next year. Was it the ACE? Is it a certain population that just happens to have more receptors, regardless if they're on an ACE, and that same population does well with ACE inhibitors because they genetically had more receptors? So, correct me if I'm wrong, if anybody knows, but in general, right now, we leave people on them if they're on them for chronic use. I don't think that I think most of us are not starting them if we know someone's positive in this current arena.
You're right again. The American Heart Association, everybody else says exactly what you're saying. And Dr. Hull and I have an ongoing controversy with each other about this, which is too much for this conversation. But there's the ACE receptor that's upregulated. There's a soluble ACE2 that is protected in the lungs. And it's a question of where does the balance come out?
Mm-hmm.
Stay tuned for that noon conference next year between Dr. Huddle and Dr. Curry.
Yes.
In the meantime, I'd like to just thank Dr. Steinhilber very much for all that she's done for our employees over the past several weeks and for taking the time to share everything with us today. Thank you very much, Dr. Steinhilber, and I hope everyone has a wonderful day.
Thank you.
Thanks, Starr.
Bye now.
Whatever day it is. Ryan, do you want to, can you copy some of these URLs or will it save? I know people wanted to.
Yeah, it's a great question, and I'm not sure.